Well, I'd like to thank you all for letting me talk to you a little bit about the open abdomen and some best practices that are out there based on data. I have nothing to disclose. We're going to cover a little bit of a brief history that shows you kind of the ebb and flow of interest in use of open abdomens. Some current best practice guidelines put out by the World Society of Emergency Surgery. We'll talk a little bit about what our current indications are and how we do it. We sort of have really tried to standardize to one method and then talk through some management issues. So historically, if you go back, Ogilvy was one of the first to really talk about the open abdomen and using it as a management strategy. And in general, he notes that you really shouldn't do it because it's bad and it's really a last resort kind of option. He acknowledged that there are some wounds you just can't close, so once you open abdomen and you can't close it, you have to manage an open abdomen. And then he acknowledged that there were certain situations where intra-abdominal infection was so bad that there may be value in reoperating and washing infection out further. But in general, back in the 40s, the outcomes were terrible. There weren't good ways to manage the open abdomen, and really because of evisceration, we didn't have a way to keep the guts in the abdomen, fistulas, how do we manage the fluids? It just really didn't work as a modality. And so for decades after this, it really was abhorred and really not a way to manage patients unless you had no other choice. And then in the early 90s, there was a real paradigm shift, and a lot of the work behind this came out of the University of Pennsylvania. Rotondo and colleagues in particular really advocated for the idea of damage control, that there are certain situations where the patient is so sick, you should do what you need to do and get the patient out of the operating room to optimize resuscitation. And they initially really applied this to trauma patients and this concept of those patients suffering from the deadly triad. So in trauma, patients get cold. As they're cold, it's difficult to resuscitate them. They become coagulopathic. As you're trying to resuscitate, they become more acidotic. They become more coagulopathic, and it's a spiral of death. And so these were the patients they advocated, get them out of the operating room, resuscitate them, come back a few days later and complete your operation. And what they were able to show with a large study was that in certain trauma patients, this worked. It improved survival. And in particular, those were patients with major vascular injuries. So they started to advocate for more widespread application of the damage control laparotomy. And then they went on to study it, and other groups took this on as well and looked at it in abdominal surgical emergencies. And really, over the next decade, it got very wide application of this principle of damage control, get the job done, get out of the operating room. And in general, the criteria were considered to be hypotension, which, as you all know, a lot of our patients are hypotensive in the OR purely from the general anesthetic, but more hypotension that truly is refractory to volume resuscitation and may even require significant pressors. Acidosis that's